Well, hello again. I'm Jason Renault with the Alternative Mobile Services Association, and it's October 2025. We're doing AMSA Talks again, and I'm with Zack Stoycoff of Oklahoma City. Hey, Zack.
Hello.
Uh, we're going to talk today about how it works in Oklahoma and about your agency, Healthy Minds, and how they've been working on 911, 988 integration in Oklahoma City. But first, let me ask you about you. Tell me a little bit about Zack Stoycoff.
Sure. So I'm Zack Stoycoff. I'm Executive Director of Healthy Minds Policy Initiative. We are a mental health think tank and collaboration facilitator based in Tulsa and Oklahoma City, focused on Oklahoma. We lead our team of 20 or so folks on the ground here and our team of national consultants. We lead collaborations and several of Oklahoma's largest cities around mental health crisis, diversion improvements, as well as policy improvements across the board, clinical workforce development, and really the whole gambit of improving mental health in Oklahoma.
Gosh, I'm talking to the right guy. How'd you get into this kind of line of work?
Well, we've had a series of generous foundations in Oklahoma who've really taken an interest in mental health. The least of which is not the Ann and Henry Zero Foundation, which launched our organization in 2019, really following the creation of a 10-year mental health plan for the city of Tulsa. And that 10-year mental health plan called for a policy-oriented, data-driven organization that would really drive change and outcomes based not on anecdotes, but on data, on best practices, on collaboration and coordination. And I was the first staffer hired for that organization. I was a lobbyist for our business community, specifically around the issues of healthcare. And so I've been a policy guy for a while, not a mental health expert necessarily, but we quickly built out a team of mental health experts that we then translate to the policymakers and we get stuff done.
And you've got some pretty established programs there in Oklahoma City that have been providing mental health care for a long time. Family and Child and their COPES program comes to mind. What's the ecological environment look like?
Yeah, so in Oklahoma, we were one of the early adopters of the certified community behavioral health clinic model, CCBHCs, which are really the backbone of our mental health crisis system in Oklahoma. We've got 13 CCBHCs that serve all 77 counties in the state. Many of them have contracts for mobile crisis responders with the state. Many of them have partnerships with the statewide 988 crisis line. We have some pretty embedded and really good providers in this category in both Oklahoma City and Tulsa. So in Oklahoma City, we've got Red Rock, North Care, Hope Community Services. In Tulsa, we've got Family and Children's Services, which has a really robust program called COPES. We've got Counseling and Recovery Services, Creoaks, and Grand, and an addiction recovery center out of Grand that is incredibly important to our state. So a robust network of providers who are willing and ready to partner with the public sector and specifically local leaders and public safety entities. And it's through that robust state infrastructure and the local collaboration that a lot of change has happened in Oklahoma.
Now, that's surprising to me, what you're saying. Being a guy in a blue bubble out on the West Coast, how did that come about? How did Oklahoma start to pay attention to mental health? And I remember looking at the Oklahoma correction system years ago, and it was a nightmare.
Well, Oklahoma is not a good state for mental health. Mental illness is higher in Oklahoma than average. Our suicide rate is higher than the nation as a whole. Our addiction and overdose rates are higher. But it is a good state for interventions in mental health. We have really started to look at how do we address this significant challenge in our state. And in crisis services, this is probably the area that Oklahoma has excelled the most.
Hmm.
How do you intervene at the point of a mental health emergency? Now, I wish we could do a lot more further upstream. And we are doing some things that are good. But at the very least, we want to make sure that if you're in a mental health crisis, you've got help. So the state has really embraced this concept. It has funded this concept historically. And really both Republican lawmakers and Democrat lawmakers see the value of this, sometimes for different reasons, but we want people to get the help they need. And we want to stop a situation that has unfolded for decades across America, right? Where we've got police officers spending half their time or more dealing with mental health and drug issues. We've got ambulance services dealing with mental health drug use, which is maybe sort of an inappropriate use of a whole ambulance, right? We've got fire departments that are so in Oklahoma, we've realized this is a bipartisan issue. It matters to everybody. Everybody's family is afflicted by this, and our tax dollars are going in the wrong place if more than half of police officers' time is being spent on.
So that's an interesting shift that the bipartisan interest, the recognizing that this is not a political issue, that this needs to be an everybody issue.
Yeah, that has played out both at the state level and at the local level, in my experience.
So both state legislators and county commissioners.
And city officials, and you name it, school officials who've gotten involved in delivering crisis services with their local mental health providers. It's really across the board. People see the value of this.
And you also mentioned police and fire. Are they coming along?
In many cases, it's the police chief who leads these initiatives, right? Who galvanizes the community and says, "Hey, my folks are seeing the worst outcomes of untreated mental health on the street, right? And so let's get together and solve this issue." That's where you bring in somebody like a Healthy Minds who can bring data and evidence and facilitation and evaluate progress so that the collaboration has kind of a backbone to it. But with those elements, you've got leadership bought in, which is usually again the police chief. You've got
Hmm.
a facilitator with who can bring data and evidence, and you've got willing partners across the board. Change can happen.
That sounds great. And so you have the need, and you have the champions, and you have the technician, and you have the political will. It sounds like things are going to be moving forward very rapidly. What's the future look like?
Well, they have been moving forward pretty rapidly in Oklahoma. And part of that is because we have had such a historic support from the state and the investment in the infrastructure of CCBHCs. Currently in Oklahoma, and you could certainly go in the news and look this up. The state has taken a few steps backwards in that regard because of some funding challenges at our state mental health agency. But local communities are not taking a step backward. Local communities are figuring out more advanced ways to partner. And so, for example, we've launched in 3 communities so far: Tulsa, Oklahoma City, and Edmond, coordinated call matrices, we call them. And it's based on models like we've seen at Los Angeles and other communities across the country who have a triage protocol for assessing what level of violence risk a 911 caller, for example, has. And if it's a low violence risk, we don't need law enforcement there.
Hmm.
Or if it's a medium or high violence risk, maybe we need a co-response team. Maybe there's a situation where only mental health goes out, right? And so we can coordinate the right response at the right time. And that's happening in at least 3 communities. I would say the next steps in Oklahoma are additional communities are really interested in this model. And I've been talking with Healthy Minds and other leaders about this. And then these 3 communities, Tulsa, Oklahoma City, and Edmond, are really taking the next steps in terms of evaluation and data and coordinated, community-wide case management and things like that that will really take that to the next level.
Well, let's drill down into the details and talk about your work in integrating 988 and 911 in Oklahoma City, correct?
Well, Oklahoma City, Tulsa, and Edmond.
Okay,
Yeah.
all three. And tell me, we know most people know about Oklahoma City and Tulsa. Tell us about Edmond a little bit.
Edmond is Oklahoma City's largest suburb. It's about 100,000 people. They were the
Oh,
first city in the state to actually have let me say this in the right way, a deep partnership with 988, in that 911 call takers can do live transfers and handoffs between 988 back and forth bidirectionally. So, for example, if a 911 call that gets transferred to 988 escalates and needs a police interaction, we can go back to 911 if we need to. And it's not a hang up and call 988. It's not a transfer to 988. It is a live sort
and
of
that's
funnel.
no mean feat. That's no just like, let's do it kind of thing. That's a difficult technical and negotiation process. Tell me a little
Absolutely.
bit about how that works, that back and forth.
Well, there's a number of challenges to overcome here, right? I mean, we've got city attorneys and others who say, what's the legal liability of our public safety or our PSAP, right, of our 911 center? If a call that ultimately needed an emergency response didn't get it because we transferred it. There are models for this. We can overcome all of that, and we have. Some communities in Oklahoma are doing this differently. So Oklahoma City and Tulsa, instead of a two-way street with 988, they're using their own mental health call takers. So in
Okay.
Tulsa, for example, COPES is a crisis call line that predates 988 out of Family and Children's Services.
Sure.
COPES clinicians are now embedded at 911 in Tulsa,
Oh,
directly
good.
taking their button seats right next to the 911 call takers 24/7, right? And in Oklahoma City, the community is doing something very similar there. So no matter how you do it, I mean, I think the what we've got to figure out is what is the best way for mental health to be involved at 911, because once you do that, you can sort of offset a lot of need from the get-go. You don't have to involve your public safety entities necessarily if at the call point you can triage to the right level of care.
Do you see this embedded 911 clinician being a permanent status, or is this some sort of transitional state, and that at some point 911 will be able to know these things independently?
Well, it, in Oklahoma, and I know in many places across the country, 911 call takers are not highly trained. We're
Yeah.
talking about you get a handful of weeks of training before you're put on a phone call and you have a script. And so, no, we don't expect 911 call takers to do the jobs of clinicians. So we do think and hope that this is a permanent situation where you've got clinicians working alongside 911. Now, in some areas of the country where you've got paramedics or others with medical expertise who are answering calls, maybe there's a capability that we don't have in Oklahoma, but currently that's the model.
Uh-huh. Very interesting. And this is, you're diverting some calls here that may, have had a normal police response.
In Oklahoma City, over the last year or so, we've seen about a 57% decrease in police involvement in mental health issues. In Tulsa, we've seen about 3,200, about 3,000-ish calls diverted that would have otherwise received a public safety response in the last 4 or 5 months that this has been operating. So the taxpayer savings are incredible. And in Tulsa alone, the savings in the last 4 or 5 months has been about 100,000, a little over $100,000 to the city,
Which pays for the whole
just by,
program. That's an enormous number, 57%. That's
yeah,
transformative.
yeah,
So
absolutely.
what's the, how does this also frees up officers to do police things?
It's a manpower extender, right? So we need our police officers to keep us safe and focus on crime. We don't need them to be mental health clinicians. They're not supposed to be mental health clinicians. The sad reality is that because we never invested in community mental health across America, jails and police have become our default mental health tools to deal with this crisis. It shouldn't be that way. It should have never been that way. And so, you see an element of this is a back the blue initiative as much as anything, right? We've got to get our police freed up to do what they can. And in Tulsa, we have heard comments from beat officers who have said to their supervisors, I'm not getting as many mental health calls. What's going on? Well, we're handling it at 911 now.
So they're noticing it intrinsically in their just day-to-day work.
Yep.
They're not asking for those calls back, I imagine.
They are not asking for those calls back. No.
And I bet your city attorneys are really happy with this as well.
Well, the reality is that, when you deploy a tool that's not equipped to deal with a problem, things can go wrong. And it's not necessarily in every case an issue of fault. It's an issue that we didn't use the right tools. And in cities across America, as you know, we see there's a high legal liability with this. I mean, we have to go respond. I'm not saying don't respond if there's a 911 call to a mental health emergency. We have to. We should deploy the best tool that we have. However, cities are seeing a decrease in legal payouts and liabilities as a result of the right tools being deployed at the right time. And in some cases, that means we're not deploying police at certain situations where we don't have to, especially when the presence of lights and a badge and a gun could inherently escalate a situation.
Now, there are some situations where a knowledgeable police response is very useful. Do you have CIT in Oklahoma?
We have CIT, and you're right. There's a place for officers to deliver scene safety, right? Make the scene safe so the mental health clinicians can go and do their job. That's the beauty of the triage model that we've developed, is you sort of assess that level of risk and you determine whether you need a co-response, in other words, an officer making a scene safe so that a clinician can do the job, or if a clinician can just go ahead and do it.
Let's talk about that triage model because that's very interesting. And of course, many other cities are in this same dilemma of how do we know who to send,
Mhm.
where and when. You learned this
Yeah,
from
so
Los Angeles.
Los Angeles is an example of a community that had a call matrix. And so what we're doing is assigning a level of risk or violence risk on a 1 to 4 level. And I think in Tulsa, we say 4 is the highest risk. In Oklahoma City, maybe 1 is the highest risk, if I recall correctly. So it's inverted, but the point is we have common language and common ways to categorize risk. So if it's a 4 in Tulsa, that is a clear crime is being committed. There is a public safety threat to others. Police are going to go. They may have mental health clinicians backing them up, but police are in the
Yeah.
lead, and they should be. Take it down a notch to 3 means that there may be a suicidal risk. There's a danger to somebody, but not necessarily to others, or there's some kind of uncertainty about that. So we may have a co-response, or we may have mental health only, but it's at least sort of a shared responsibility sort of approach. If it's a 2, go down even further, then we're talking about it's likely just a mental health responder, or we may be able to handle that call on the phone because the data show us that when a clinician can take a phone call, most of the time they can actually resolve a situation without any response at all. And if it's a 1, we're talking about 911 call centers get these kinds of calls all the time, but they're just requests for information or general wellness sorts of things like a wellness check, but there's no real danger. And it would be a low priority call for a police officer who has to go respond to a murder or something like that, right? But we're able to then just sort of put that in the hands of the mental health responders who can go and do a wellness check or can make some phone contact or something like that.
And it's sounding quite marvelous as you're rolling it out, and you're very well saying these things very well. But this is a terribly complicated technical task and a lot of moving parts and constituents here.
Yeah, very much so. There's politics involved in all communities that I've been aware of, right? I mean, there's different constituencies who need to be represented. It's not as simple as applying a broad or blunt instrument. And once you start getting into the weeds of this, you've got to start talking about, the hearing and hard of hearing community, the deaf and hard of hearing community, right? Communities who have disabilities like vision or physical disabilities. You got to talk about what do you do with somebody who's experiencing homelessness and maybe they're experiencing homelessness and they have a serious mental health issue. You do have to have a crisis receiving center, ideally in a community, right? So if you need to go somewhere and it doesn't need to be jail, and it doesn't need to be a hospital emergency room, you have somewhere to go that's a mental health triage point. That's got to be a part of the solution for this. But then sometimes it's, we've had conversations about partnerships between the mental health responders and other kinds of nonprofits who serve and know communities better than the mental health responders. So there'll be instances where COPES, for example, will call an organization that advocates for and with people who are hard of hearing. And they'll send an interpreter out and that sort of thing.
It sounds like the fuel for this machine is your data analysis, your data collection. How is that going? What are you doing to collect and use data?
So many of our partners do collect and use data, but it's historically been for their own purposes, right? So the mental health folks know what data they want to collect to show their success,
Yeah.
and police know what data we have to all agree on what data collectively shows whether we are getting a better system. And sometimes that requires new data collection points. So for example, if a police officer goes out to a call that was logged as a mental health call or not logged as a mental health call, and they have to call 911 back and correct whether that was a mental health call or not. Well, we want to know that because we want to know if we're appropriately freeing up officers' time to do their jobs. If we don't know that a call was or wasn't actually a mental health call, once they get out to a scene, we can't do that. So you've got to have a protocol to then go back to them. So that's been a struggle, right? Because, you've added something else for officers to do. And does the data system at the police department, interact with the data system at the mental health? Probably not, right? And so in Tulsa, we've attempted to bridge those divides by layering on a new data system, Gelato. And our fire department has acquired this software and is, sort of spearheading multiple entities and putting their data in it so that we know if you get a mental health call for somebody who's been in contact with a different system historically, we know how to kind of coordinate the resources that we're going to give that individual. That's hard work. That's the next generation of this work is data sharing and figuring out how to really case manage and triage across systems.
Right, because someone who in a crisis is not going to use just one doorway. They're going to bounce around quite a bit, and being able to track that over space and time is pretty essential in helping resolve the conflict, the crisis. Are you able to share this information with others? Is this expandable beyond the community mental health and police?
That's the ideal world.
Hmm.
And in Tulsa, there's a dashboard that the public can access that can show you how well the system is working, at least in diverting police and fire and ambulance. I'm happy to provide that URL. But there's a lot of data that's not involved in that dashboard. It's just not either collected appropriately, or there's different data definitions. So it's going to take some time to really see the nuances of this play out in the data.
Well, that's a stunning achievement just to get these two parties in the room together and talk about doing something. So it sounds like you're well underway with this huge effort. What does the future look like for you?
I think the future looks like continuing to establish those metrics. What do we all agree we want out of this system, and how are we measuring it? And ultimately, how are we holding each other accountable to doing what needs to be done in a collaborative and friendly way as much as we possibly can? That's the next generation of this work. I think it's involving the community even more through data and through bi-directional sharing on what's working and what's not working. In all three communities, we've got the operators together. They've improved the system, and now it's time to start that continuous improvement process.
Mhm.
Not that we're not doing that, but to really ramp that up, I think is where we're going.
Thanks, Zach. Thanks for helping us know how Oklahoma works.
Appreciate it.